you guys know about us. I mean, I'm Tejinder Singh, and I have Dr. Steve Fort with us. And this is the topic of our presentation. I'm going to talk about complex pelvic dysfunctions and how they should be treated and assessed. Okay. The first part of the lecture, I think will focus on Shahid, and Shahid is here. You should thank him for helping us do this. And he'll be sharing his detailed history, because I think he can give you like a 10-year history of how symptoms progressed. And I'm sure he's not the only one. We see complex pelvic dysfunctions all the time in the clinic. I get so many calls from patients about that. I'm sure Dr. Steve sees it all the time in the clinic. I mean, and that's why if your approach is very specific and you know how to assess accurately, know the research, know the background of information that is available to us, you can definitely make a change in your patients' lives. So I'm going to give you like a very vague history, but I think I have Shahid here, who's going to give you like a very, very detailed history. So Shahid is 35-year-old male. He saw me back in March, and he reported bilateral hip low back pain. And with him, the symptoms shifted from right side to left side. Sometimes he would get flare-ups on the right, but recently the left side has been bothering him more. He denies having any history. He's a very active person, played high school football, has lived in Austin for many, many years, Austinite. The patient, and he has several physical therapy treatments. I mean, I've seen probably 10 to 15 therapists, like a lot of therapists.
A lot of different therapists.
A lot of different therapists, and with very little success. Had a steroid injection, which definitely helped him. And as you guys know, we sometimes use injections for like diagnostic purposes. So that definitely explains that his symptoms are SI related or pelvis related. Okay. When I saw him, he told me that back in March that he would get like one severe episode every month, right?
Yeah, once every month.
One severe episode every month, and then obviously when you get like severe pain, your level of activity goes down. You take pain medications, and the symptoms would get better, but symptoms would come back again every month. Okay, so he's a nurse and he has a very active job profile. I mean, he has to help patients, and most of the factors most of the aggravating factors were running, lifting, work-related activities, and sitting in cross-leg. Tylenol was a relieving factor. He will take medications. He's seen a pain specialist, a spine specialist, an orthopedic surgeon, and probably 10 to 15 therapists. So Shahid, you can come and sit here and just talk about your detailed history. I think I've told them some, but I'm sure you can go back and explain your detailed history. Like, I think, yeah, you can start from when you were in college and stuff like that. So
Hi, everyone. I just wanted to give kind of a background of what happened to me. I never really had any health issues, never really had any pain. I ran like twice, 3 times a week. I played multiple sports when I was in high school. So when I started having this pain, I was in college, just another day, I was laying down and all of a sudden I got this excruciating pain and it was in my buttock, not like your typical SI joint area where you usually have pain, but it was like right deep in your right buttock area. And I was telling myself, what in the world is happening to me? Because it was so severe that it took me 6 hours just to get up. So in my mind, I was just trying to process, what did I do? I really didn't do anything out of ordinary. I was going to school. I played basketball with friends, just regular gym, nothing really crazy. So I managed to get up, moved around a little bit. I said, oh, maybe I pulled my muscle, like maybe I did something wrong. Not a big deal. I really didn't think 10 years later it was going to be haunting me and it was going to like affect me in every aspect of my life, from walking, working, spending time with my family. So I started having pain, kind of went away after like 4 to 5 days. I really didn't think much of it. I was like, probably I pulled something, went away. 6 months later, it came back, like same areas and like in your right glute area. So I started noticing a pattern. Every 6 months, 5 months, it would keep coming back. So I saw a physical therapist. They thought maybe it was piriformis muscle. But one thing that I noticed, that people really didn't like assess you, like they really didn't figure out what was the problem. It was like a lot of guessing game. I saw multiple physical therapists, like the first 7 years, 10 years, maybe 10 to 15, 20 therapists, at least really good ones that I could find that could help me out. But it wasn't much of a relief, at least for me. So first 7 years of my life, I mostly had pain in my right buttock area, and it only stayed on one side. I never really had pain on my left side. So it didn't travel down. It was very local. If you guys have any questions, you can interrupt me and ask me questions. Sorry, I did. So, so it was mostly my right glute area, local. I thought maybe it was sciatic, maybe it was piriformis. I wasn't sure. I didn't think it was nerve-related pain because it was very local. It felt like really deep pain. So, and then towards the last 3 years of my life, the pain shifted to the left side and has mostly stayed on the left side. But pain always remains like on one side. It's never right and left side simultaneously having pain. So it's either I'm having pain on the left side or the right side. So yeah. So after being really, really desperate, because it was really affecting my life really badly. So I thought maybe I had piriformis muscle. And at one point I even thought about like having a muscle removed, because I was like, I got to get rid of this problem. I got to find a solution for myself. So that's when I really sought out and saw a pain specialist here in Austin, Texas. And he was the first person that hinted that I may have SI joint issue. And I don't even remember him physically assessing me. He just like, I pinpointed where I was having the pain. And he was like, you know what, you probably have an SI joint issue. Let me refer you to an orthopedic specialist. When I went there, they kind of assessed me. And they were like, okay, you know what, you probably have SI joint. Let's do a diagnostic test and your steroid injection in bilateral SI joint. So I did the diagnostic test, but the crazy thing is the diagnostic test is only useful when you are in extremely like having extreme pain. So the problem was, when I was in pain, they didn't have any openings to see me. So when I did have the diagnostic test, I was in pain, but I wasn't having like severe pain, like 10 out of 10. So when I did do the diagnostic test, it brought the pain down. So they were thinking maybe, you know what, you do have SI joint, and they gave me a steroid injection, which I got a total of 3 treatments, and it kind of did help me. But the reality was my problem was a mechanical issue. They were trying to fix it with the chemical solution. So it was only masking the problem. So you can't really fix a problem that is mechanically messed up with the chemical solution. So one day, like I was just was desperate. I was like, oh, I've already tried everything. Maybe my next thing is I have to get the SI joint fusion surgery, which I really didn't want to get any surgery at this age because I'm only 34, 35 years old. So, but I was desperate. But when on Saturday, I was just looking up, I was like, okay, SI joint. I know what I have. I think I have an SI joint problem. That's how I came across TJ. And when he saw me, and he was like, oh, you're in like major SI joint dysfunction. I didn't even know what that was. And since then, I think I've seen him since March. So I was having flare-ups every month. I was having to deal with this. Like it was excruciating pain. I couldn't like really work. I couldn't go for a walk, spend time with my son. It was like really affecting me in all aspects of my life. So when I would have this flare-up, the pain would last like 2 weeks. So now I think in the last 4 or 5 months, I've had like one bad flare-up. I'm still not there where I want to be. So I still get like this mild discomfort here and there. So I'm working out and hopefully getting stronger so this pain completely goes away.
Yeah. So thank you for very, very detailed history, Shahid. Very detailed. Because I probably can't give that much details. I mean, I think you did a good job in explaining this. So let's talk a little bit about the previous diagnosis. I mean, he's seen multiple therapists, fellowship trained, a lot of therapists. I mean, he knows probably more therapists than I do. So previous treatments were diagnosis given was piriformis syndrome. And I mean, if you've attended our lectures previously, we don't actually believe in this diagnosis. And previous treatment, orthopedic consults, seen a pain physician. You see Dr. Amasha, Dr. Amasha, Rami Amasha. Had steroid injections, acupuncture, massage, cupping, and physical therapy. I mean, yeah. If you remember teaching our last class, I mean, we were talking about that acupuncture has some evidence, massage, cupping has very, very poor evidence for low back hip pain. Okay, I'm going to do a little assessment on him, but let's talk a little bit about research, what research entails and what research we have. We talk about Laslet cluster. Laslet back in early 2000s gave these 5 tests to diagnose SI problems: your distraction test, compression test, thigh thrust, sacral thrust, Gainsleyan. I think if you look at article by Van Wulf 2006, he used the similar 5 tests to diagnose SI problems. The diagnostic accuracy is very, very good. If you have 3 out of 5 are positive, the sensitivity is 0.91. So statistically very, very good. But the problem with Laslet cluster is it does tell you that this person has SI issue, but doesn't tell you what kind of SI issue. Okay. So this is very, very helpful to nail down SI problems, but it's not very specific. It doesn't tell you what kind of SI problem patients can have or your patient has. Okay. So to nail down the problem, we tend to use a little bit of osteopathic literature where we perform these 3 tests, which we call dynamic palpation: your sitting flexion, your standing flexion, and your Gillette test. Okay. If your patient is in a lot of pain, standing flexion test is not very helpful, or Gillette is not very helpful. Yeah, you can definitely combine Laslet cluster with your sitting flexion test. So I'm going to demonstrate sitting flexion test, and I'm going to talk about specific findings regarding my patient here. Okay, so let me demonstrate sitting flexion test, and then we'll go back on Shahid's finding and how we were able to get him some relief. Okay, Shahid, do you mind facing? Okay. So just I want to just sit here. Okay. Yeah. You want me to sit here? Well, sit but face that way. Okay, sit face that way. Yeah. So sitting flexion is a very, very simple test. Your patient is sitting, their legs are rested on the floor. Yeah. Yeah. And all you have to do is find the PSIS. Okay. Yeah. And ask the patient to flex gently. So go and gradually flex for me. Lean forward. I don't see a side to side difference right today because I think we treated him a few days ago. So come back to me. Okay. Lean forward again. And then come back. Yep. Yep. The side that goes superior is your dysfunctional side. But the problem is, because we are doing a side to side comparison, what happens if patient has dysfunctions on both sides? Okay. And that can really, really mask your findings because you ask the patient to, do you mind flexing again? Yeah, patient to flex. Now you're looking at the PSI as one's dysfunctional side going up, but if both sides are dysfunctional, if you have dysfunction in both sides, I mean dysfunction in the right side as well as left side, the diagnosis and assessment becomes very, very difficult. Okay, and that's why we don't rely on one single test. We rely on combination of tests. Okay. Okay. Thank you, Shahid. You can leave it back. Yeah. So we're going to talk specifically about, if you guys have any questions regarding anything, please ask the question in the chat box. Okay. Okay. So when I saw him back in March, I think I saw him on 4th March, if I remember the date accurately. The range of motion, lumbar range of motion was normal. Hip range of motion was normal. Actually, he's very, very hypermobile in his lumbar spine. Okay. We did a supine to sit test. We found right posterior nominate rotation and left anterior nominate rotation. I'll demonstrate this. And then we also found like right unilateral sacral flexion and left unilateral sacral extension. He was reporting a lot of left pelvis, hip, SI pain, glute pain. Okay. And if I just have to simply demonstrate this, this is your sacrum, right? This is the left side. This is the right side. Okay. This is something like this. Okay. And this is anterior. This is posterior. Okay. So sitting like this. And if you have seen patients with unilateral sacral extension, you know that it could be very, very painful. A lot of patients who present with unilateral sacral extension present with 9 or 10 out of 10 pain. Okay. Especially when they're in dysfunction. Okay. Yep. I want you to read R and L, so that will give you a good idea. Okay. I know the screen is backwards, but just I want you to read right. So if this is the left side, okay, and this is unilateral extension. And what it does, it causes unilateral, okay, does cause the sacrum to go in unilateral sacral flexion on the opposite side. And that's why he reported bilateral symptoms, but either he was painful on the right or painful on the left. Okay. And that makes our diagnosis very, very difficult because in sitting flexion, we're comparing side to side difference, right? And if we're comparing right side with the left side or left side with the right side, it becomes difficult if both sides are dysfunctional, but one side is painful. Okay. If that makes sense. Okay, I will demonstrate the supine to sit, and then I'll discuss something else because I think I was missing a point, and I will show you something which I think we have discussed in the past, but I'll have a discussion on it as well. So, Shai, do you mind laying me back? So, supine to sit is a very, very simple test. Patient is in supine lying. Okay. You ask the patient to bend their knees. Okay. Lift up your back for me, please. Yeah. And then square the pelvis. Come down, please. Yeah. Extend your legs for me. Okay. Yeah. Yeah. You You check for the medial malleoli. Okay. Sit up for me, please. Yeah. Yep. And then you check the malleoli in sitting position. Go back a little bit. Yep. If you remember the mnemonic, if the leg becomes short to long, it's posterior rotation. If it becomes long to short, it's anterior nominate rotation. Simply, if you're good with static palpation, lay on your back, please. You can just confirm your findings by just palpating the ASIS. You can just confirm your findings by just palpating the ASIS. And you'll probably be able to see whether if it's anteriorly rotated or posteriorly rotated by just checking the ASIS. Yeah. The idea is to perform multiple tests so that your diagnosis is accurate. Okay, and you can definitely combine Lasseter's cluster as well. Okay, so here what I see is neutral today, but on the day one, I could find that it was something like this. It was anteriorly nominate rotation on the left and posterior nominate on the right. Yeah. Yeah. Let's talk a little bit about secondary dysfunctions, because what happens is if you have chronic dysfunctions, if the dysfunctions have persisted for a long time, you start to develop like secondary dysfunctions. I was very, very surprised when I was able to reproduce his glute pain, hip pain with mobilizations or posterior anterior glides to T12, L1, L1, L2. This definitely surprised me. Can anybody tell me which anatomical structure gives you, I don't want to give this away, gives you posterior hip pain when you palpate T12, L1, L1, L2? If you attended the Magnus syndromes lecture we did like a few months ago, you probably know the answer. Can anybody tell me what structure originates from T12, L1, L1, L2 and supplies your posterior hip? Anybody? That's a great answer. That's a great answer. Very surprised that you were able to answer this. That's a great answer. Okay. Superior cluneal nerve, and specifically your perforating branch. Okay. Okay. I think I was having a discussion with one of you where they were able to reproduce groin pain with manual palpation of T12, L1, and that is your anterior branch of superior cluneal. Okay. So you do have nerve supply to the posterior hip, anterior hip, and lateral hip from thoracolumbar junction. Whenever you're assessing your pelvis, make sure that you're assessing thoracolumbar junction. It's very, very important. Okay. Very, very important. Okay. Let's show you the objective findings. Hip external rotation was 3+ on either side. Posterior gluteus medius was 3+. We know that with all the SI dysfunction, posterior gluteus muscle is inhibited. Okay. Enough research out there, enough literature out there. I think there have been hundreds of studies published on this. So straight away, if you're finding SI problems, L4, L5 problems, please, please, please check posterior gluteus medius. Okay. Can anybody tell me why this patient has weakness in hip external rotators? Anybody? Why do you think his hip external rotators are weak? Anybody? We know that SI inhibits your posterior gluteus medius, but why this patient has issues with hip external rotators? Anybody? Overactive? There is a similar piriform is attached to the sacrum. Not all external rotators are attached to the sacrum, right? We have 6 external rotators of the hip. Anybody? If you look at this finding, hip range of motion normal in all directions, but restriction in hip internal rotation, intra-articular hip problems, which are usually secondary to any SI issues, will inhibit hip external rotators. Okay. So SI dysfunctions will inhibit PGM, which is posterior gluteus medius, and intra-articular hip problems will, or any restriction in the hip will inhibit hip external rotators. Okay. And that's why regional interdependence is so important. You can't just keep treating one area. You have to go up and down and break the biomechanical pathway. You have these primary dysfunctions, secondary dysfunctions, and muscles not able to activate and produce force. Okay. And of course, hamstring dominance. I'm just going to quickly demonstrate hamstring dominance because, and his hip extension was also reduced. Okay. So, okay. Try laying this down. Yep. Yeah, so how do you check hamstring dominance? You keep one hand on glute max, one hand on hamstrings, okay? And you ask the patient to slowly lift up the leg without bending the knee, and slowly lift up the leg for me. And yes, you will notice that hamstring activates before the gluteus maximus kicks in. Go down, please. Okay, do it again for me. Yeah. And that is hamstring dominance. Hamstrings are supposed to be knee flexors and not primary hip extensors. Okay. Okay, I think so let me explain this. I think so there is this hospital in Colorado, they primarily see hip patients, and they've done like tons of research on hip problems. And they've found that all the intra-articular hip problems, any restrictions in the hip, pre-surgery or post-surgery, can cause weakness in your 6 hip external rotators. Okay. If you have bilateral pelvic dysfunction, you're going to have some intra-articular hip restrictions. Okay. And that will inhibit your hip external rotators. Okay. And that's why you're seeing these findings. Okay. Yeah. Okay. Yeah, I'm going to quickly talk about the treatment, how we approached it. The treatment was very straightforward, but we were facing some clinical challenges, and I'll explain why. So when I saw him first, we knew that it was left unilateral sacral extension and right unilateral sacral flexion. I will show you some of the techniques I used. And there was secondary dysfunction, was thoracolumbar dysfunction. So our first session, this is the manual therapy techniques we used. But the problem I was facing is every time I would treat him, he would feel great, but 6 hours later, he will contact me that I'm in severe pain, because I would align him and he was not able to just maintain it. He would, like 4 hours later or 6 hours later, he was back in dysfunction. Okay. And that happens. I mean, if you remember the foundations lecture, we talk about our body following the path of least resistance. I can explain about sacral palpation. Okay, so Shahid, I can use the nose bracket, please. Just use the nose bracket. Yeah. And I just need to demonstrate this. Yeah. Yep. So how do you find sacral base in Iliac? I'm going to demonstrate that. Okay. What you do is you find the PSIS first, and this is the PSIS. Okay. Find the PSIS first, and then what you do is you rotate your thumbs 45 degrees. Okay. And then you go up and medial. Okay. And then you go up and medial, you can find a kind of a divot. That's your sacral base. Okay. Coming again, find the PSIS. Just go underneath the PSIS, you'll find a ridge, and then you rotate your thumbs 45 degrees, and then you go up. Okay. And then you find the sacral base. In case of unilateral sacral extension on the left, sacral base should be very, very prominent like this. Should be much higher, extremely tender to palpate. So be gentle, especially, okay? So you'll find this. So if I have to show you on this, okay, this is the sacrum, okay, and unilateral sacral, this is the sacral base, okay. It will be like this, okay, sitting like this, causing the innominate to rotate anteriorly on the left, causing the innominate to rotate posteriorly on the right. Okay. And this is prominent in tender. And what it does is it causes the dorsal SI ligament to be in extreme tension. And that is usually your pain generator. That gives you that 10 on 10 pain you're looking for or you're finding in patients. Because when this goes in extension like this, the dorsal SI ligament is in extreme tension. Okay. And that will be a pain generator. I'm going to show you the Iliac very, very quickly. So going back to the PSIS palpation, find the PSIS. Okay. Go 45 degrees up and find the sacral base. And then keep your index finger on the sacral base and make like a complete rectangle. And you find in the hip, you'll find the lateral edge of the sacrum, which is your inferior lateral angle. So you're finding the sacral base, and that's why. So you're finding the sacral base, okay? And then you're finding the lateral most tip of the sacrum, okay? If I have to show you here, try to find this spot. This is the Iliac. You're not finding this. You're not finding. So follow the sacrum, find the sacral base, and try to be on the lateral edge of the sacrum. Okay, lateral edge of the sacrum. Okay. Now, because this is sitting like this, causing dorsal SI ligament to be under extreme tension, we have to do something so that the dorsal SI ligament calms down. Okay. Some people try to do needling, which can help. Just help needle but the underlying dysfunction still stays. Okay. They might feel better temporarily because dry needling does bring in some opioid mediators, but if the underlying dysfunction still stays there, you're not fixing anything. You're just giving them temporary relief. Okay. So make sure that you do some manual techniques, and I'll demonstrate like a very simple, very, very simple technique for unilateral sacral extension on the left. Okay. All you have to do is come here. Okay. Bend patient's knee, abduct. Okay. And if you're not sure, I would encourage you to abduct a lot. Okay. And external rotate. Okay. Now what you've done is you've opened the posterior SI. Okay. When you do external rotation, you open the posterior SI. Use your pisiform and put it on sacral base. Okay. Put on sacral base. Okay. And then ask the patient to press on your hand. Okay. Ask the patient to press on your hand. Count for 1, 2, 3, 4, 5, and then let it go. Okay. You can repeat this 3 to 4 times. Okay. 6 to 8 second holds. And you can sometimes do 2 to 3 sets. But the idea is once you do the muscle energy technique, go and recheck the sacral flexion. Go and recheck the sitting flexion. And also you can try doing lastlet cluster. You can also do lastlet cluster post wave mobilization. Another important thing is, and this is with regards to this patient, and you'll find this all the time. From session 1 to 5, we focused on aligning the sacrum, but we also focused on improving thoracolumbar mobility because that was giving you the secondary dysfunctions. Okay. You were having symptoms here, but you're also having symptoms in the thoracolumbar area because this has been going on for so long that this patient started to develop secondary dysfunction. I remember doing a PA on the left. If I can just show you this. Doing a simple PA on thoracolumbar, left side facet, T12L1, L12 facet. And Shahid told me that he can feel like severe pain in the hip. Okay. If I just align this and don't work on this, this will keep coming back. Okay. And that was our clinical challenge in the first 5 visits. I would align him. I would do the mobilization. I would treat L5S1. I would align the sacrum. Post-testing, post-mobilizations, manipulations, his symptoms would go from 9 or 10 to 3 or 4, but it would come back in 6 hours. Yeah, because the body follows the path of least resistance, and he was just going back and forth from in dysfunction to out of dysfunction, in dysfunction, out of dysfunction every day. I remember seeing him like 3 to 4 times in the first week, just because I would align it and it would just go right back. Okay. Yep. So the idea is, please make sure that if you see patients like chronic patients, try to find for secondary dysfunctions, because you're going to have secondary dysfunctions. Maybe manipulate the hip. You see me doing bilateral hip manipulation here, because treating the intra-articular problem was important to kick in those external rotators of the hip. Okay. Okay. Treat the L5S1, treat the T12L1 just to calm down that superior cluneal nerve. Okay. Superior cluneal nerve. Okay. So session 6 to 10, because I was not able to maintain it, I introduced SI belt, and I'm going to show you the SI belt we use on me. It is mostly used in patients who have, in pregnancy patients, but I mean, if you have difficulty maintaining the alignment and you're doing the correction and the patient still continues to report pain after the correction and you're not able to maintain the correction, you definitely should use SI belt. And as you know, it improves like foam closure. We're going to talk about foam closure and force closure in our next lecture, but I encourage him to wear it all the time, especially when he's working, except when he's sleeping. Okay, so I'm going to just demonstrate this very, very quickly, how you should wear SI belt and how you should. Okay, so this is SI belt. Okay, you can find them. All you have to do is find the most lateral most point of the hip. Okay. Okay. And put it on. Okay. But the key thing is, make sure that your patient is not sitting in dysfunction. Because they're sitting out of dysfunction. You have done all the corrections. And then you can, what it does is gives you like kind of a passive restraint or foam closure. Okay. But you only do this when you can align the patient. Patient is sitting in dysfunction and you squeeze something, it's going to probably make their symptoms worse. Okay.
Hey, TJ.
You have a question, Dr. Steve?
I do. Hey, listen, since the SI belt, I'm sorry if the background sound is very loud. If the SI belt is dark and your clothes are dark, do you think you could just put like a sheet or a towel, something light or something white so they can see where it sits? I know you're describing where it sits, but
Can you guys see it, or do you want me to? I can definitely use like a pillowcase or something to actually show you.
we can also show next weekend, we can show it better with over some light clothing.
I can show you with the pillowcase where it should sit. Very, very. Yeah, so what you can do is you can find the GT, the greater trochanter. Okay, it should not sit on your umbilicus or on your lumbar spine or on your L5S1. It should sit on your greater trochanter. So find your GT, which is usually the most lateral most point of the hip, and it sits there. Yeah, it doesn't sit here, which is your lumbar belt. It sits where your GT is, your greater trochanter is. Yeah, I hope it makes sense. Yeah, and only introduce this belt if you are able to align the patients. If you're confident that you align the patient, last leg cluster is negative 3 out of 5 or 4 out of 5, and your sitting flexion is negative. Yep. Yes. So what we did was we introduced hip external rotator activation, posterior gluteus medius, gluteus maximus activation, and we reduced the hamstring activation because he's very, very hamstring dominant, tend to use a lot of hamstring for hip extension. Okay. Sessions, I think I've seen him a lot. So you can see sessions 10 to 15, his symptoms were calming down. And we tried to wean off the belt. I asked him to wear the belt only when he's working, and he works as a nurse, like 12-hour shifts. So he was wearing belt when he was only working. And on the other hand, we progressed the exercises. We added resistance to hip external rotators. We did posterior gluteus clamshell 2 and 3. Gluteus maximus activation still continued. And then we added more functional stuff, which we do it all the time. Or nothing great about these exercises, but they're very, very helpful in activating gluteus medius, hip external rotators in like functional positions. Okay. Currently, we are here where he would get like an occasional flare-ups, which I call it like upslips. He would get like these mild upslips, 2 or 3 pain. He had only 1 episode of unilateral sacral extension after he went for a massage or something. I mean, he had 1, but we were able to address it like in few hours and he was fine. Okay. Additional exercises I add, he's doing planks with clamshells, and I'll demonstrate some of the exercises that reduced hamstring activation. Okay. We are doing some step-ups to develop like functional strength, doing some mini lunges so that he can activate the glute max and glute med in single leg standing position, hip thrusters, which he doesn't like very much, and then wall squats. Okay. I will demonstrate some of the exercises you can do to reduce hamstring activation. And yeah, so I'll just demonstrate. I mean, even if you're cognizant about what active insufficiency and passive insufficiency is, you can easily reduce hamstring activation while doing glute max exercises. So So a simple bridge, if a patient does a simple bridge, this is simple bridge, okay, go down, okay. And this can activate both your hamstrings and glute max. But what if I do a bridge from here? Like bend your knees more, bend your knees more. Now, knees are flexed, really flexed. Hamstrings are actively insufficient. Okay, now do a bridge. And this is purely glute med or glute max. Okay, so you can encourage more knee flexion with hip extension. You can do the quadruped hip extension with knees completely flexed. Okay, I can go down, Shahid. Okay. I will show this. We didn't do this with Shahid, but I can show you one more exercise where we can reduce the hamstring activation. Can you come on your all fours? Can you come on your all fours? All fours like you like. All fours is like this. Yeah. And this on this end. We didn't do this exercise with Shahid, but I mean you can definitely include it in your regimen. Okay. And you can ask the patient to bend the knee and then raise the hip. Okay. So make sure you maintain that knee bend. Okay. So you can ask the patient to take the heel towards the ceiling. Okay. You can always add like knee flexion to hip extension. Okay. I think we'll share the video on YouTube for you guys to see. And yeah, I will demonstrate some of the exercises we have recently added. Okay. Okay, Shahid, can you demonstrate us planks with clamshells? I will probably use this one. So we are at the stage with Shahid where we'd get like occasional flare-ups, and our goal is to get him like functionally stronger. Okay. He would get these mild upslips. And I think he had like one episode of unilateral sacral extension, which we were able to manage within a few hours of. Okay. So I'll demonstrate some of the functional exercises because I think these are very, very handy, especially if you're in like later stages of rehab. Okay. Can you do the plank with
When we did it last time?
Yes. Okay, so some of the functional exercises you can teach your patient. They're able to activate obliques, and then you can, yeah. This is a very good exercise if you're trying to develop like functional strength. Yep. Yeah. Another exercise could be a step up. Yeah. So and then come back down slow. Make sure that when they come down, the eccentric control, eccentrically they're coming down very, very slow. Okay. Come down very, very slow. Good. Okay. Can you, I'm going to show you many lunges. And just like make sure that when they're doing it, they're not internally rotating, because the tendency is to internally rotate when they do a kind of a mini squat or mini lunge. Okay. Yeah. You can come back and sit there. Okay. Another exercise you can do is hip thrusters, which I will demonstrate. Okay. Actually do a setup. Okay. Yeah. So either you can use a barbell or dumbbell, and then your patient is doing. If you feel like your patient is using a lot of a lot of hamstring, you can always flex the knees. Flex the knees a little bit more. Flex the knees a little bit more. Yeah. And then, or you can use a, if you don't like dumbbells, some people like barbell. Yep. Okay, thank you, Shahid. Okay, another exercise you can use is kind of a wall squat. Yeah, we can. Yeah, so, and this is a good endurance builder. You can activate like upper extremity activity or anything. You can hold a weight just to activate the upper core, obliques. You can go like add like D1 patterns, D2 patterns with it. Yeah, you can be creative with this exercise, but the idea is to improve glute activation and glute endurance primarily. Okay, you can sit here. So primarily the idea is to keep the patient out of dysfunction and improve the force closure. You can temporarily use the foam closure by using a belt, but I mean the long-term goal should be to improve force closure. Okay, and we'll be discussing tons of exercises next lecture. I think we've added like so much stuff in the pelvis course, and so we'll be talking about tons of exercise ideas, different levels you can do. But the key thing here is you should be proficient with assessment, you should be proficient with treating it, and you're proficient with manipulations. Anything you want to add, Dr. Steve?
One sec. Let me get my sound right. Okay, can you guys hear me okay? Can you hear me okay?
We can hear you, Dr. Steve.
Okay, fantastic. So all I wanted to say was you guys, Dr. Singh went through that and made it seem pretty streamlined and seem pretty easy. That's a very complex, very complex patient. And he was treating the patient correctly, but still after 6 hours, the patient was falling back into dysfunction. But he treated the patient appropriately. He had patience and he knew how to deal with this type of situation. And you guys, I just got to say, and I've said it a million times, I'll say it again, like the ability to treat SI dysfunction effectively is something that distinguishes a basic physical therapist from a highly advanced physical therapist. Dr. Singh was one out of 16 or however many therapists this patient has seen. And I just got to tell you guys that, you know, the training and credentials that Dr. Singh and I have, even amongst people with that training and those credentials, the number of people that can treat this type of situation effectively is hopelessly low. If you guys want to, I mean, I just got to say, like, we want therapists all over the world to be able to evaluate and treat SI dysfunction effectively. And that's what next weekend is all about. We'll be teaching it next week online. Dr. Singh and I will be together. So we'll have really good demonstrations and really good lecture and stuff like that. And then, of course, when we come to India, this is like one of our flagship courses. You know, we're going to be teaching it in the USA this year a couple of times. We'll be teaching it in India when we come in October. So join into the lecture next weekend, get a little bit, and then come find us either in the USA or come find us in either Bombay or in New Delhi in October when we're there. And you guys can get the real thing and hands-on. So yeah, taking the class once, you should probably try to come to online and in person is my personal opinion. I spent a long time with Dr. Singh learning this stuff. And so it does take repetition. And the more times you get it, the more you'll be able to remember and apply. So yeah, all I can say is this is worth learning. Put forth the effort and you'll be glad that you did. Thank you, Dr. Singh, for a well-done lecture.
you. I will demonstrate hip manipulations, probably the very, very simple technique. Okay. Okay. Yep. So hip manipulation is very straightforward. Patient is in supine lying. Okay. What you do is you flex AB duct, external rotate. Positioning is important. If you're using the right hand, if you're using the left hand to is your force producer, you can keep the left leg back. Okay. And all you do is just lean back. Okay, lean back. Okay. Find the end point and thrust it. Okay. So the loose back position of the hip. Loose back position of the hip is flexion, abduction, external rotation. You take the patient in the end range and just thrust it. What you're doing is you're doing a quick adduction on you. So you're doing this. Okay. So you flex AB duct, external rotation, and just a quick thrust. Okay. I'll also show you the SI manipulation. Okay. I'll demonstrate like a one-man technique when you don't have help. Okay. You can use this. Okay. Come here. Okay. You AB duct, extend, internal rotate. Okay. You can grab the patient's leg in your thighs. Okay. Yeah. Yeah. You can keep your hand to block the sacrum. Okay. And you try to go in the end range by extending your hip. And you do a quick thrust. Okay. It can be slightly challenging if you're doing it on a bigger person. Plus, if the patient is much larger than you, but you can definitely do it like this. Okay. It's much easier on a smaller patient. Okay. Any questions you guys have? But I think I believe that assessing and treating SI joint will make you stand out of an average PT. And Shahid is not the only patient. I have several patients who have failed physical therapy in the past. Because I mean, SI is a very complex joint to assess and treat. Unless you follow a very structured and a very specific approach, it's very, very hard to manage it. Okay. Okay. I think as far as SI course is concerned, me and Dr. Steve are teaching an online SI course next weekend for 8 hours. I think it's 4 hours on Saturday, 4 hours on Sunday. And then me and Dr. Steve are also teaching the same course, a 3-day course in Texas, in Dallas and Brownsville in the 1st and 3rd week of September. Okay. That is approved for 30 credit hours. Okay. Okay, let me actually show this because as I'm asking this question. So if a patient has, consider this as a right side, this is a left side. Okay, and you can look at L and R. Okay, if patient has unilateral sacral extension on the left, okay, this is unilateral sacral extension on the left, you will either have an anterior innominate or an inflare. Okay, anterior innominate or inflare. Okay, if you have a unilateral sacral flexion, either you'll have a posterior innominate rotation or an out flare. Okay, out flare is when your pelvis is flaring out. Posterior innominate is when your ilium decides to do this. Okay, anterior innominate is when your innominate goes forward or in. if your SI patients are reporting morning stiffness, I would encourage you to test other segments. Maybe they have secondary dysfunctions you're missing out on. Especially if you're seeing chronic patients, patients who have symptoms for a long time on and off, please, please, please find secondary dysfunctions, because you're going to have areas which you're not addressing. And those areas are still contributing to patients' symptoms. Okay. Like with Shahid, I mean, I wasn't expecting to find like thoracolumbar dysfunction, superior cluneal nerve entrapment. And that's a whole totally different diagnosis. Magnus syndrome is a totally different diagnosis altogether. But because the symptoms have been gone for a long time and untreated, you're starting to see some presentation of mild presentation of Magnus syndrome. Okay. So if you're seeing a pregnant patient who has SI problems, be very, very gentle with manual techniques. Okay. Aligning or correcting a patient who's pregnant is very easy. Very, very easy. Even a gentle grade 1 mobilization, because if you understand the arthrokinematics, your SI joint is floating in water. Okay. You don't need manipulations to correct it. All you need to do is a very grade 1, grade 2 mobilizations, and you can correct it and just maintain with a SI belt. Okay. Pregnancy, treating SI joint in pregnancy is a totally different, it could be a totally different lecture. So let's not talk about this today, but lower lumbar facet hypermobility dysfunctions mostly, can contribute to morning stiffness. So that's why I'm saying, look at L5, S1, L4, L5. Okay. Just don't look at SI joint. Make sure that you're looking at secondary dysfunctions. You're looking at thoracolumbar dysfunction. You're looking at hip restrictions. You're looking at mid lumbar, upper thoracic. In some situations, neck. I'm seeing a patient currently in the clinic who has upper cervical dysfunction and upper and pelvis dysfunction. And when I mobilize the pelvis, I mean, I feel like I can reproduce cervical pain. And when I mobilize the cervical spine, I can reproduce the lumbar pain. So make sure you're always looking at region interdependence, especially in your chronic patients, because if they're not getting better, you are missing something. It's your fault. You're missing something. Make sure that you're looking at secondary dysfunctions. Okay. Any more questions you guys have? I mean, I'm going to stick around for 5-10 more minutes. And if you have any questions, I mean, feel free to share in the chat box. But I think you guys should thank Shahid for doing this for us. I mean, because I'm sure you're seeing complex SI patients in the clinic. Okay. Yeah. I think one of you is sharing the case study. You're just telling me the symptoms. I want to know what your findings are. Did you do the Laslet cluster? Did you do the sitting flexion test? Did you do supine to sit? Did you do prone knee bend? If you can give me those findings, I'll be able to comment on the diagnosis. You can't just look at subjective findings and try to find the diagnosis. And that's why I like to follow a structure. You take the patient history, let the patient talk for like 2 to 3 minutes, or maybe sometimes 5 to 10 minutes if they have a long history. Listen to them, what they are saying, and then go to the objective findings. Okay. And then follow the structural assessment. Okay. The structure we're trying to teach you through this course. And then combine all the findings and then come to the diagnosis. And his diagnosis was missed because probably nobody was listening to him, what he was reporting. Make sure that you listen to your patients and combine all the findings. Okay. You're correct. If one side is in unilateral sacral extension, other side would be in relative flexion, but we always name the dysfunction based on the symptomatic side. Okay. If somebody is presenting with pain on the left side, we are calling it a left unilateral sacral extension. But because he had symptoms previously, I would say that he had a right unilateral sacral flexion, which usually gives you piriformis pain, which is your buttock pain. And that's what he was reporting and he was giving his history. One of you is sharing the patient's history with asymmetric rotation. I think for asymmetrical torsion or rotation, more likely than not, I've seen that patient has pelvic floor issues or like symptoms of incontinence, urge incontinence, erectile dysfunction. So if you're finding this L1R or R1L, make sure that you give them some questionnaire where you can ask about bladder function. Okay. Usually you will not, very rarely you'll find like L1R or R1L and patient does not have any incontinence or any of the, and bladder function is normal. Unless it's very acute, then possibly it can happen. But I mean, if it's like chronic asymmetrical torsion, you will find some form of bladder involvement. Yeah. People are thanking you, Shahid. But any more questions you guys have? What is the cause of knee pain and unilateral? I mean, knee pain can be secondary to, which is common, unilateral sacral extension and flexion. I think both are common, equally common. I've seen unilateral sacral extension being more common, but I don't know the research or data on it. Most of us are not even diagnosing and treating it. So it's hard to find like which is more common. I mean, a lot of us are missing it. Pudendal nerve can be affected by SI dysfunction. Absolutely. Absolutely. I've seen it. Absolutely. And pudendal nerve can get affected. I think I've seen it in asymmetrical torsion being the culprit. So yes, pudendal nerve can get affected in SI dysfunction. Yeah, especially in asymmetrical torsions. But the research and data is so limited in SI dysfunction, and half of the PT community doesn't even believe in SI dysfunction. Okay, so that's why the data is not there. But I can tell you that, I mean, recently orthopedic section of APTA is adding more and more research on SI joint, adding more and more literature on SI joint. So we are definitely moving in right direction, but I mean, we're not there where we should be. Okay, and that's why I feel like treating pelvis is I think with unilateral sacral flexion. So that's why combining findings is important. With unilateral sacral flexion, you will find sacral base being deep, but patient will present with a lot of hip pain. Asymmetrical torsion, you might find like patients with bilateral pain. With symmetrical torsion, you'll probably present with pain in the anterior chain, hip or knee pain, if you're talking about symmetrical torsion. Okay. Usually unilateral sacral flexion present as a very dull, achy hip pain, which they can't get rid of. Okay. Unilateral sacral extension, on the other hand, present as a very sharp, annoying, your dorsal SI ligament is on fire kind of pain. Patient would report 9 or 10 pain. They can't move, they can't function, they can't get out of bed, something like that. Okay. Sacral flexion usually presents with 5 or 6 pain, dull, achy pain in the buttock, where they feel like their piriformis is on fire. Okay, but it's not as severe as sacral extension. Sacral extension patients are like, they don't like to move. Sacral flexion definitely has more sacrotuberous and hamstring component because it causes posterior nominate rotation. Posterior nominate rotation affects the posterior chain more. So you can have hamstring pain, sacrotuberous pain. USF can give you sciatic-like symptoms because in certain situations, the sciatic nerve passes through that greater sciatic knot. So it can get entrapped and give you symptoms down the leg, but not in all patients, some patients. So, I mean, this is when you talk about radiation, and if you look at, I think we're going to talk about this more in the SI lecture, but I'm just going to give you a little synopsis. If you talk about SI referral pattern and you look at the literature given by pain physician, you can look at the literature given by osteopaths, chiropractors. SI can refer pain anywhere in the leg. I've seen patients with SI pain, SI dysfunction and pain just in the tibialis anterior muscle or anterior lateral leg, and everything else is okay. So if you look at all the literature that is present, SI can refer pain anywhere in the leg. Because, I mean, yeah, if you just Google SI pain and referral pattern, you'll find like hundreds of research articles talking about SI pain and different referral patterns. Some referral pattern given by pain physicians, some referral pattern given by orthopedic surgeons, some referral patterns given by chiropractors, some referral patterns given by osteopaths. So in my experience, I think you can find anywhere in the leg, and that's how you should look at SI pain, because pain can be radicular, referred, pain can be because of secondary dysfunctions, right? That's a good question. I mean, yes, you should treat pelvic dysfunction and see if you can change the patient's symptoms. If you can change the patient's symptoms by treating pelvis, then yes, that is a referral pattern of the pelvis. Okay, so patient is asymptomatic in the pelvis area, but reporting, I saw this older gynecologist a few years ago. He had no pain, severe pain in anterior lateral leg, and no pain anywhere else, and had like a massive pelvic outflare when I saw him. And he had an ultrasound of tibialis anterior muscle done. It was negative. We aligned the pelvis, his tibialis anterior pain was gone. He had no symptoms anywhere. Just pinpoint severe pain on lateral leg, proximal anterior lateral leg, okay, where your tibialis anterior muscle sits. So the answer is yes, but follow the structure. When you're treating the leg, doesn't matter what the diagnosis is, do a quick pelvis assessment, okay? And in certain situations, if you can correlate your findings with the pelvis, any leg symptoms, you're on the right track. And if I can change the symptoms by treating the pelvis, then yes, I'm treating the right thing. That's how physicians work. They give you injections. Same thing. It's like diagnostic injection. Give you injection. If it gets better, okay. That's the problem. Yeah. Any more questions, guys? Yeah, it can cause malleoli pain as well. Any more questions? People are thanking you a lot, Shahid.